Hi, I'm Dr. Pajari, and this is the Prognosis, the Palliative podcast, and today's episode is Hospice Encounters of the Difficult Kind. Medicine is unlike any industry that you work in, and at the same time, it has some similarities to other industries that I'm sure people can relate to. It has good places to work, good environments to work in, and it has also environments that can be counterproductive and environments that can even be toxic to work in. This episode revolves around discussing what makes a hospice or end-of-life care a good environment and what makes it maybe not so good of an environment. And my guest today is Evelyn Perez-Rivera. She's back and will be back for more. And we're going to have a continued discussion over time of hospice encounters of the difficult kind. So welcome today.
Thank you. I'm glad to be here.
So we've talked about this many times about what about our difficulties and our challenges in trying to work in an environment that's not easy. What would you say, in just talking about things openly, what would you say is a good hospice environment to work in?
Well, we have worked in many different hospices. We have worked in the healthcare industry for a long time. And when it comes to hospices and what is an ideal hospice, is an environment where is this teamwork, that you have good quality nursing, that you have good quality physician, that you are really being attentive to the needs of the patient. That for me is the best environment in order for the patient to receive the most out of that experience, and for the families too. When it comes to a good hospice environment also, you have to have a good support system. That hospice company also needs to be aligned with that same vision on how we're going to support the patients and their families.
Mm-hmm. And, I can think of certain times where I've worked in a very good environment, and then I can think of times that I've worked in not such a good environment. I agree. I think the good environment was very much about everyone being aligned, or almost everyone being aligned. Sometimes there's, from the top down, there's an impasse or a break between upper management and lower management, or upper management and those out in the field. But at least if you have an alignment between those who are out in the field, clinical staff, physicians, CNAs, and the interdisciplinary team, you find that it can go pretty smoothly. And, tell me a little bit, what do you think about that impasse there? Because we've seen that before too, between upper management and those out in the field, that there can be a disconnect.
Yes. So it's important for the upper management to also be clinical, because when you have an understanding of what goes on in the field, you are better prepared to support your staff, your interdisciplinary team. And that trickles down. Those are the values and the mission of the hospice. It becomes clear because you have been in the field. For myself, that I have been in every position within hospice as a nurse and now as the director, I have to understand the in and outs of what happens in the field in order to make it a good hospice. And we then can identify when things doesn't go well. Then you can say, things could have been better here. But having that understanding and being able to walk that walk as a nurse, as a case manager, as a CNA, with your CNAs, with your interdisciplinary team, then you can then identify and be better prepared to support. But I understand, going back of the upper management upper management, they need to have the time and understanding in the field in order to prepare them to better support that team.
I mean, I totally agree. I think that's something I've seen over my career so far, is that sometimes you have people running medicine who have a degree in management of some sort, but have had no exposure. They're non-clinical. Mm-hmm. And I always think, how can that be? They don't understand what it's like to work overnight. They don't understand shift work necessarily. They don't understand the difficulties in patient encounters or managing certain situations. And I often think, we've talked about that, wouldn't that be helpful for them to actually shadow and go out into the field and see really what the reality of medicine is? I mean, is that something, tell me a little bit more, because I know you've had different roles. So have you had conflicts in those situations where, if you're working with someone who really doesn't seem to get it, how things are happening out in the field versus having an idea of just running a business? They think they know.
Exactly.
Tell me a little bit about your thoughts there.
So picking from the business standpoint, I'm going to give an example. You might have the administrator and the owner of the hospice completely non-clinical. And of course, they are looking at things from the business standpoint, which is not a bad thing. It's not a bad thing. We need to have a balance. But not understanding what is needed and what your staff needs and how critical it is to, for example, have nurses. That makes the job very hard for the existing nurses. And the one that gets the short end of the stick, as we say, right, is the patients. Because whenever you don't have the right staff and the right expertise and the right experience, all that kind of just creates more work for the physician, more work for the case manager, because they have to do more, and there has to be understanding from the top to put the right people in place, and also understand when it comes to the financial standpoint what is needed to have a successful experience for the patient and their families. Because at the end of the day, that is who benefits, and we have to create that environment. There is a lot of myth about what hospice is, and how can I say, when it comes to those beliefs, it's hard to move people to change in to a different mindset. And whenever people come with preconceived ideas of what hospice is and have a bad experience, that just makes the experience terrible. And as upper management and the right staff, that is the great combination to a great hospice, having the same vision, the same mission, and in supporting those patients.
I was thinking about something I had discussed with some colleagues at one point about, which one was more important as a priority. We do focus, in my training, it was very much a mantra of patient-centric, and I believe in that. But I don't think you can be patient-centric if you're not employee-centric. Don't you agree with that? Mm-hmm. It's a pretty deep concept. People are afraid to say that, but if you're not doing right by your employees, especially, let's be honest, the ones who go out in the field and carry your business, if you're not honoring that, you're not going to be able to ever accomplish patient-centric. And I think that's always, that's something that is lost.
In trying to achieve that.
And trying to achieve with the wrong focus.
Yes.
Have you had examples of that? I mean, I know we've worked together for a while, and we've talked about things. You know, what examples come to mind where rather than kind of creating a culture of employee centricism, right? There's this idea that, well, we've got to take great care of the patients, but, you know, to the exclusion of supporting staff, and then it becomes a very difficult situation.
Well, there is a current phenomenon when it comes to nursing, for example. The field is very competitive. There is a lot of need for nurses. And there has been many times when you hire a nurse that don't have the expertise to come into the hospice arena. And you hire that nurse because they are a nurse, but not because neither their mission or their vision doesn't align. Their belief is this is just another nursing job. And as we say many times, there are no do-overs when it comes to death and dying. And you have to understand what you are doing and what you are seeing. So having the right staff is critical. Is critical. You need, in order for you to be patient-centered, you have to be employee-centered because you need to hire the right candidates for that particular experience.
I agree. I mean, I know we've talked about that before, that I rely tremendously on what is clinically being given to me. That's kind of the model that we have in place, which is different than laying hands yourself on the patient per se. But you rely on that. And if you have someone who's not giving information in a way that's clinically relating back to the dying process, or an understanding of decline, or even a good clinical foundation, you can easily, quickly not get the picture straight. I mean, it's a very tricky situation. And, you know, they may miss transitioning.
Yes.
Or they may misinterpret something else for transitioning. I've had that happen.
How many times you have had patients that have they are experiencing certain symptoms and they just get there is a lot of anxiety. There is a lot of this. So, well, there is terminal agitation that it might be that patient might be already in that cusp to start transitioning, and it is showing those symptoms that we see all the time. But if you don't know what you are seeing, then you are going to report it as Dr. Pajari. They are very anxious. And when in fact, there is another process happening.
Yeah.
And you're not recognizing it as a nurse.
Well, and I think also another thing is bringing more clinical back to hospice. It is, you know, it's not it is a touchy-feely area because of the very nature that it provokes a lot of emotion, right? So people end up then having a lot of emotion about this process, and we want to package that in a way where people feel better about it. So there's that side. But nonetheless, and this is something where I'm pretty sure that we're not doing it justice kind of globally, is we're not applying strict clinical standards or trying to make it as clinical as it should be. There's a very clinical aspect to decline and a very clinical aspect to dying. And, you know, we haven't done studies. I mean, again, because of our fear of dying and because of our dislike of discussing, and that's where this whole podcast comes from, we don't really examine clinically, or we haven't done the studies clinically as to what is going on, you know, and understanding that from a lot of different standpoints. You know, I don't know. So I think that's kind of an important point too, is bringing back the clinical and making sure people are trained from a clinical standpoint and making sure people understand clinically what's appearing in front of them. You know, we do need vital signs. We do need to have a very thorough assessment of the patient where they are, and from there you can manage certain symptoms or certain things, perhaps in a little bit of a different fashion. And then as you become better and better at recognizing what's going on, from a decline standpoint, then you start also understanding what triggers transitioning and when is it really irreversible versus reversible. So I was just mentioning that because the clinical, I feel a lot of times people get into, maybe we get clinicians or nurses coming into hospice and perhaps not feeling that it's as clinical as the hospital,
Yes.
for example.
There is a belief out there, and we try not to. We don't practice like that. I know that we don't, but we have worked in other hospices where that is the way it's done. But there is a trend that happens when patients are declining, and just going in and just providing the emotionality to the patient and their family, that's not enough, because there is clinical evidence that when this is happening, this is where we are. And whenever you're asking for vitals tells us so much. In my work as a case manager, I was able to see the trend. If you start putting all the vitals every time that you are seeing that same patient, you're going to start seeing a trend. And I have had nurses that just go in and forget to do the vitals or forget to communicate what they are seeing with the physician. And Dr. Pajari, the other thing is, you are a very unique physician when it comes to hospice, because the majority of the physicians that are out there kind of just fit into that idea that you really don't have to do much, and that they are only three medications, and that is all we need. With you, it's very different. And that is the right way. We have discovered the right way to do hospice, and I know that we have. And the evidence is the management that we have done at the end of life, and the report and the feedback that we have heard from families, because they have gone into the right way of thinking about hospice. Hospice is not the 11th hour. We can do so many things. How many times have we admitted a patient? They have come into hospice very, very sick. Things have turned around, and we have even discharged them. Mm-hmm. Because they have stabilized. Mm-hmm. So that's very important, understanding on how to do hospice the right way. But then going back to the support of upper management in the company, and also having everyone on the same page, and your interdisciplinary team needs to be on point, as we say, right? On point. And patient focus, but you have to hire the right people in order for you to be patient focused.
Yeah, absolutely. Well, we were talking a little bit, so I think from a nursing standpoint, clinical, and good communication. Well, I wanted to ask you about that. My mind was triggered when you were talking about the communication aspect. So we just talked about with a good hospice, we're trying to examine what makes a good hospice versus not. One is a nursing staff that is very honestly clinically secure, not just in the ways of keeping things going, the aggressive medicine side, but also from a standpoint of starting to understand about decline and then transitioning, being very solid in that realm. So clinical is important, but we were just talking about communication, and that also trickles into the interdisciplinary staff too. But communication, so that's a big one too, yes. And you were touching on that. Yeah. Let's talk a little bit about communication. I think that's people come in and they think, we don't need to communicate. We can operate in our own way and just go and see a patient and not communicate any information, or we don't necessarily need to really talk about things.
Talking back about communication and how important it is to have good communication from beginning to end. Now, we all know that coming into hospice, people have different perceptions of what hospice is, let alone that perception of hospice, but then each family member even have different perceptions. So often what happens is that we might talk to the main caregiver, and they might or might not be on board on or accepting on the decline of the actual patient. Yet somebody else in the family, in the immediate family, it might be, a child, an adult child. They are in better understanding of where the patient is and preparing themselves to lose that patient. So having communication in it from the beginning on who are the main players in that family makes a tremendous difference when it comes to the actual care. Many times, as we have a pre-conference. We get the referral, and it's just on black and white. There is a lot of clinical there. There is a lot of little details, but that's not giving us what's going on in that family. And having a pre-conference, it helps us identify what the expectations are. In hospice, there are a lot of times when we encounter families that just do not know what hospice is, or what can hospice give them, or how can hospice help. They just seem to think that patients will come in and there is nothing else. They are just at the 11th hour and they just die. And there is so much more to that.
Yeah, I think if there were one thing that we could change about the perception, I'm hoping we can, but if there's one thing, it is that there is so much that can be done, not the opposite, and that this actually deserves, people spend so much money for all sorts of medical care. And then when it comes to dying, which is a guaranteed process.
They just don't even want to talk about it.
They don't want to even touch it, talk about it. And then we pretend like it can be whittled down to a very simplistic process. I've said this before, that doesn't require much management. I don't know if that comes from modern media, or if it's a perception that comes from, again, a dying patient is on their bed but still talking and interacting. Are these things coming from film or misrepresentations of the dying process? Have we strayed so far from, we used to have patients pass away very commonly at home, and people probably witnessed that. Have we strayed far from that with modern medicine? And we're trying to shift back into getting patients home to pass away. But, I mention that because I think that, absolutely. Fundamentally, people think that this is such a simplistic process, and then yet this is actually the most important process that we're here for. Mm-hmm. It defines everything, and yet somehow we've relegated it to, let's not think about it. Let's not even worry about it. It'll come at some point, but we're not going to think about it now. Mm-hmm. But you're guaranteed that it's going to come at some point soon. Mm-hmm. Time goes very quickly. Mm-hmm. And, we don't need to really medicate or manage any aspect around that. We don't need to have an understanding of how it happens, why it happens.
I don't have to do any final arrangements,
right?
Because we are not there.
Yeah,
that's what we hear over and over.
Yeah,
and many times I used to say all the time when I was in the field, better to have it and not need it than need it and not have it. That is so important. Just to have things lined up, have a open communication. I think that having that pre-conference, just for us to understand the expectations in where they at in the continuum makes a difference. And once we admit that patient, having the conversations again and circling back and understanding really where they at is so important. The other thing that happens in hospice is that it is very seldom that the patient and the families speak to a physician. That is something that we don't do, because all of our patients come in and we have a pre-conference, and you are so on top of how your patients are doing. But that communication makes the difference in what the outcome is, how the outcome plays out, and even the satisfaction in the grief that happens on how managing the grief after that patient passes.
Yeah, absolutely. That's so deep. The communication. So having a discussion with them beforehand. We get a lot of hospital patients having a discussion about, they may be on 15 liters non-rebreather coming out. I don't think people realize how critical these patients are coming out. So having a conversation about wound care, how are we planning this? Or if I see any red flags or any difficult issues, having that upfront conversation before they come on board, even assisting with prognosis. If I see that there's an impasse between what the family seems to be thinking, because I can gauge that from the clinicals or from what's being presented and then where they are. So having that upfront conversation and absolutely continuing to have input along the way. It may or may not need to be very frequent. We've had families where it was quite a frequent conversation that I needed to have to continue to reinforce prognosis, to continue to give them education on where we were. Some other families require less, depending on how accepting they are of the process and how they are understanding medically what's occurring. So having those continued conversations, one of the big conversations that I think that I have often with families is, and I do this on purpose, is right around the time that I see a patient about to begin to transition. I think it's important to discuss with families, because they still, even though they may see something, they still might not recognize it for what it is. And I've even had, I've spoken to you about this too, I've even had families where I've given prognosis and we are there, we're at the active transitioning phase, which is going to be probably on average, around 72 hours, maybe 4 to 5 days. It can be longer, but we see that process coming up. And I had one family recently, if you recall, that said, we don't believe that. We don't think that that's what's going on. And I said, well, that's okay. I trust, I understand. I said, I understand why you feel that way, and I just wanted to impart this information to you so you understand what I feel is going on, and we will continue to support you and continue to put that comfort care in place in the right way with the right dosing and the right medications. The patient did pass away, and I think at least offering that to them, even if, they weren't accepting at that moment, and even if after they're still struggling with it.
That's complicated grief right there.
Yes, but I will say it's far better to have that happen than to have not had that conversation. That's a big one. Not to have had that communication, not to have had that instruction. At least they heard the message. Whether or not they were accepting, that will settle more in them over time, hopefully, than not having had any information and having a patient suddenly pass.
Exactly.
And them not understanding that that patient was actually about to pass, but nobody gave them that information. Yeah. Communication is huge. And I require also, just to let you know too, you know this, but I require also communication very much so with the nurses. You know, my style is different. I want to know what's going on, and I want to make sure we're managing things in a way that correlates to what's going on also.